Well, let's just wait a few more seconds, but in the meantime, hello everyone. My name is David Hurtado. I'm an associate professor at the Oregon Institute of Occupational Health Sciences, and I'm the host of today's seminar. Happy New Year! And well, we all are looking forward to 2027. And, but today we're all starting with a fantastic speaker, someone I'm very grateful is here with us today, someone whose work has inspired my work, and someone who has taken interest in our check-ins work. So I appreciate that. And so I'm delighted to introduce today Dr. Bryan Sexton. Bryan is the Chief Wellness Officer of Duke Health Integrated Practice and the Director of the Duke Center for the Advancement of Wellbeing Science. After 30 years as a psychologist, psychometrician, and investigator, he now works with leaders to assess and improve culture and workforce well-being. Bryan has conducted and published large studies and randomized controlled trials, showing how to cause enduring improvements in the well-being of the workforce. He has authored over 100 peer-reviewed publications, and his research instruments and well-being interventions have been translated and used in over 30 countries. So yeah, we're delighted that you're here, Bryan. Fantastic way to start this year. And just a few more admin updates since there's been an updated link. I will copy, so if people join later, although we have 24 participants already, I'm going to copy your bio in the chat. As you can hear, I'm recovering from a sinus and ear infection. So if you are in the participants panel, you can ask questions directly as opposed to having me read your questions in the chat. I prefer not to do that today. Other than that, I think you're good to go. Thank you, Bryan.
Thank you, David. What a pleasure to get to share this with you all. I hope you'll see the obvious connections between our work and work that y'all are doing there. They're very obvious as I get about a third or so, or maybe halfway through the presentation. So just today, as a quick overview, I want to let you know that I'm going to give you a quick crash course in the well-being landscape for healthcare workers. It's been kind of interesting these past a few years. I want to talk about well-being informed leadership strategies. This is something that Colin West likes to call just leadership, but I think we have to be a little bit more deliberate about it. And then also resources to share. So the good news is if you're paying attention and you find this stuff useful, there's going to be plenty of stuff that you can copy and paste and use on your own if you like. I do like the model put forth by Tate Chanefeld and Mickey Trockle at the University at Stanford. That's where they talk about the three kind of components of occupational well-being. They talk about kind of the culture of wellness. They talk about individual factors, things that you can do like for your work-life integration, and things that you can do to kind of recover after kind of an emotional upheaval. We all need lots of those tools in our tool chest. And then there's stuff that you can do to kind of make the workplace better, like ambient listening technologies, AI, things that make your life easier as a healthcare worker. We're going to talk about content that really overlaps all three of those components of occupational well-being today. But just for the next, let's just say 40 minutes or so, please don't think of well-being as how happy you are. Instead, think of well-being as your ability to do stuff. So as your well-being is compromised, your ability to do stuff is also compromised. No wonder healthcare worker well-being is the best predictor we have for things like clinical outcomes and operational outcomes. We'll show you the data from that as well. I'd like to start, though, at the beginning. The very best place to start to talk about well-being is not just are you well? If you want to understand how to predict subsequent well-being, we actually find the best place to start is looking at your work-life integration. Your work-life integration today predicts next year's well-being really well. And we do this using not are you satisfied with your work-life integration, but rather we look at, because work-life satisfaction is related to marital satisfaction, it's related to life satisfaction, but it's only a mediocre predictor of your actual well-being. Instead, we look at behavioral frequency. So how often in the past week, how frequently in the past week did you skip a meal? How often did you eat a poorly balanced meal? How often did you work through a day and not take any breaks? did you get home late from work? How often did you have difficulty sleeping or change plans because of work, or feel frustrated by technology? That's a fun one. Or my favorite, how often did you get less than 5 hours of sleep during one of the nights in the past 7? The responses to these questions give us a real window into the behavioral frequency of your work-life infractions. How often are you kind of letting one kind of overwhelm the other? And that tells us a lot about where your well-being is going to be next year. So this is the canary in the mine, if you will, the crystal ball that tells us where your well-being is headed. Now, we eat our own dog food at Duke. We've done this work for a long time. We have almost 400 work settings across the Duke University Health System. And you can see that work-life balance, when you measure it across all these work settings, it varies from something like 10% reporting good work-life integration to 100% reporting good work-life integration. However, that's a lot of variation from 10% to 100%. If work-life integration was how you were taught and how I was taught, then work-life integration is actually just, you have to be able to say no. You have to be able to kind of have good boundaries. You have to be able to kind of take care of yourself. That's not what these data suggest, because if it really was an individual difference, if just a pure individual difference, this would be a straight line. But there's tremendous variation, which tells us there are some work settings, maybe you're aware of these work settings, there's some work settings where everybody takes a break during lunch. And there's other work settings where nobody pees at work. There's some work settings where everybody takes a break. There are other work settings where nobody leaves on time. And that is a function of where you work and what your colleagues are doing. So your work-life balance has a social contagion effect. It's very interesting. Your work-life balance impacts others, and their work-life balance impacts you. That's not just an individual difference. It's more complicated than that. In fact, we've done this looking across all kinds of different healthcare worker roles, residents, fellows, and attendings. So physicians are here on the left-hand side. They have the worst work-life integration. Nurses are in the middle. Over on the right-hand side, we have psychologists, dietitians, environmental support services. But look, the variation here ranges from like 40% to 80%. I just showed you that 10 to 100% is the variation by work setting. So it matters less what letters you have after your name, or whether or not you have letters after your name. It matters more who's to your left and who's to your right on any given day. In fact, we can look at how long you've been in your current role. If you've been in your current role for less than 6 months, you've got pretty good work-life integration. It takes about 6 months to kill your spirit, and then you look like everybody else. People who work days tend to have better work-life integration. People who work 8-hour shifts tend to have better work-life integration. But here's the nugget I want to leave you with here at the very beginning of this tour de force through the well-being data here is there a social contagion? Yes, there's a social contagion. Whether or not you skip meals impacts whether or not I skip meals. Whether or not I skip meals impacts whether or not you skip meals. Whether we're aware of it or not, it's just a contagion effect. Now that tells us where your well-being is headed. So you can burn the candle at both ends now, but there's going to be a price to pay later on. That's why this is a predictor. That's why behavioral frequency is a predictor of subsequent well-being. How, though, do we best measure well-being? Well, that's a different question altogether. What if I were to tell you there's one measure, there's one metric that's so powerful, it can measure your quality improvement capacity. That's a cultural dimension. What do you think of your nurse manager, your medical director, your local leader, your manager? What do you think of your teamwork climate? Can you speak up? Can you resolve conflicts? Can you ask questions to clarify ambiguities? What do you think of your patient safety climate? Do we do the right thing for the right reason for the patient? And then what do you think of your work-life balance, which we were just talking about? What do you think of your burnout climate? How crispy are your colleagues, right? And what about your emotional thriving? Are you really flourishing? Are you really, what does your professional fulfillment look like? And then emotional recovery, how readily do you bounce back? So what if I told you there's one measure that predicts all of those measures, one ring to rule them all, and that is emotional exhaustion. It is a very powerful metric. And we've been talking about this for a while. Healthcare worker emotional exhaustion is the best predictor we have for patient engagement, infection rates, medication error rates, and even standardized mortality ratios. It is the best predictor we have. In fact, this slide is 10 years old. This isn't even new. We've known about this for a long time. And to get into the contagion component of this, let me just illustrate something quite interesting. If you look at school teachers and you look at their emotional exhaustion, teacher emotional exhaustion predicts teacher mental and physical health, teacher retention, quality of instruction to students, and student outcomes. Just like healthcare worker emotional exhaustion predicts healthcare worker mental and physical health. It even predicts things like divorce rates, immune system function, traffic accidents, all, like you name it. It predicts healthcare worker retention, quality of care to patients, and then patient outcomes. So this is giving us some hints that, yeah, there's some social contagion stuff there. In fact, this is wonderful data from Lottie Derby at the University of Colorado and Colin West at Mayo Clinic. They have actually shown that for every 1 point increase in emotional exhaustion, just 1 point increase, you're 20% more likely to step away from the bedside, which is fascinating because we've been tracking data from emotional exhaustion from healthcare workers for a long time. Since before the pandemic. So from September of 2019, so before the pandemic, same 30,000 people in September of 2020. So it's during the pandemic, but before vaccines. That was a hot minute. Remember that? And then again, same 30,000 people in September of 21, which is after vaccine mandates. It's after Delta, and it's right in the middle of Omicron variant. Remember that? So same 30,000 people, fair to say, 3 very different times. What's interesting about this is that no one came out unscathed. There was some variation based on your role, but by the end of the pandemic, everyone is worse off than at the beginning. Every single role, no single role, healthcare worker role, came out unscathed. And how much was this increase? Well, it was a 27% increase in emotional exhaustion. It's an almost 9-point increase. I want you to just remember that. A 9-point increase during the COVID-19 pandemic. That was a big increase in emotional exhaustion across the board for folks. That's the equivalent, if you want to like put this into perspective, the impact of COVID on our well-being was the equivalent of going live with 2.5 to 3 different EMRs back to back in 1 year without any break in between. You would never do that, and that's why it felt so different. Now that was then. We have some more current data, which we are writing up now. This is a manuscript in preparation. It says the only thing I'm showing you today that's not already published, everything else has already been published. This is in prep. We actually saw that physician emotional exhaustion spiked in 23 and it stayed high. So it's worse than a coin toss if you're a physician. Nurse emotional exhaustion has stayed high. It actually went a little higher in 2024. So it is now worse than a coin toss if you work in healthcare as to whether or not you are meeting the criteria for emotional exhaustion. And that says a lot because last year, let's just put it this way, last year sucked. 2025 was a year when there was an assault on science, there was an assault on healthcare. Academic medical centers in particular really took one to the chin and then took a couple of gut punches at the same time. What happened last year was that people, they felt threatened with a riskier future. And when you feel threatened with a riskier future, you have to pay attention to everything. And when you're having to pay attention to everything, that is exhausting. And that's why we're picking up these signals using these metrics like emotional exhaustion. You can pick up on the increases in burnout, the increases in emotional exhaustion in particular, as a result of 2025 just being a really rough year. We do this internally. I like this definition of well-being as the ability to do stuff. I think the best metric for the ability to do stuff is emotional exhaustion. We know that healthcare worker emotional exhaustion is a really good predictor of physician intentions to leave, APP intentions to leave, nurse intentions to leave, but also look at the negative relationship right there with leadership behaviors. What that means is that as much as emotional exhaustion tells us who's going to stay and who's going to leave, it also is related quite significantly to what I think of my boss. So let me ask you a question. How many of you have ever met someone who is happy and content, but they have a shitty boss? I mean, I'd like to meet that person. I haven't met that person yet. The way we feel about our leadership and the way we feel about our well-being is intricately linked. It's very hard to disentangle those things. So let me ask this question. Is there this emotional exhaustion contagion thingy as well? Does it have that social contagion? Yes, it does. In fact, we collected data with the Michigan Hospital Association across 31 hospitals in the state of Michigan, and we actually found an ICC for this of 0.26. That's let me say that ICCs are interclass correlations. This is like inter-rater reliability. Why on earth would there be inter-rater reliability the way when you're asking healthcare workers what they think of their well-being, when you're asking all the healthcare workers within a clinic or within a work setting, and you're comparing them between work settings? Why is it that there's inter-rater reliability within a work setting? Let me put this another way. 26% of any one Michigan healthcare workers, any one Michiganders' emotional exhaustion, 26% of it was predicted by the person to their left and the person to the right on any given day. Let me say that another way. A quarter of your well-being is who you work with. That is not something I learned in my training. I don't know if you did. but that's certainly news to me. A quarter of your well-being is who you work with. Yikes. Again, there are individual differences in well-being, but there are group effects as well. There's these social contagion effects. This is why we don't treat it as such, but burnout should be a team sport. We should be measuring it at the group level. We should be intervening on it at the group level or group level-ish whenever we can. That's not to say that individual level interventions aren't useful. They are, but we have to recognize that we have to impact things at the group level in order for it to have the impact that we really want. It's also explaining this wonderful anti-motivational poster. If you've never gone to www.despair.com, I highly encourage you to check out the anti-motivational posters like this one. Burnout attitudes are contagious and mine might kill you. That's actually what the data are showing. Your misery rubs off on me. My misery rubs off on you. That is normal. In fact, your drama becomes my boat anchor and I am sinking. And that is a normal response to the suffering of others. In fact, if you're the kind of person who is not vulnerable to the suffering of others, that doesn't make you well. In fact, that's the textbook definition. If you're not vulnerable to the suffering of others, that's the textbook definition of being a sociopath. So if you are indeed vulnerable to the suffering of others, what it means is that, congratulations, you're not a sociopath. That's a good thing to know. It's not that you didn't get enough training. It's not that you didn't try hard enough. It means that you're not a sociopath. Congratulations. But just like the burnout of others can pull you down, the well-being of others can pull you up. It's a social contagion, and that goes both ways. I love the study that came out just before the pandemic. Having a happy spouse is associated with a lowered risk of mortality. Yes, for every 1 standard deviation increase in spousal happiness, your mortality risk goes down 13%. That's a whopping drop in your mortality risk based on the happiness of your spouse. Spousal happiness, social contagion. If you've got kids in college, soon to have kids in college, or recently had kids in college, I meet all 3 of those criteria. This is a really interesting look at depressions. Usually at the University of Notre Dame, this is where they did the study. They have random kids, college freshmen, assigned to random dorm rooms. But this particular year, they screened all incoming freshmen for depression. And they put into each one of these dorm rooms, there's 103 of them, they put in each one of these dorm rooms 1 depressed roommate and 1 non-depressed roommate. Doesn't that sound like an evil TV reality show? Then 1 month into the freshman year, they screen them both for depression again. 6 months into the freshman year, they screen them both for depression again. And 1 month in, the non-depressed roommate had symptoms of depression. Isn't that lovely? And 6 months in, they are ding, ding, meeting the diagnostic criteria. But wait, there's more. The depressed roommate was able to offload so much of their junk onto that unsuspecting roommate that by 6 months, they are doing significantly better. That is because it's a social contagion and those go in both directions. Isn't that interesting? We see evidence for the social contagion in work-life integration. We see it for emotional exhaustion, for spousal happiness, and for depression. In fact, I'm a psychometrician by training. I develop metrics and then validate to show that those metrics are measuring what we think that they're measuring. And I have to tell you, every time we have a good metric and a good sample size, we find evidence for the social contagion. It's just, when it comes to well-being, we just see this evidence all over the place. Now, let me kind of go a little bit deeper. I'm a stubborn scientist. It took me a long time to figure this out. True well-being is not just being happy all the time. That is not what we're finding. In fact, true well-being is the ability to see the good and the bad without focusing on one of those things at the expense of the other. Because if you are treating your well-being like a t-shirt and you never change the t-shirt, yesterday sucked and today sucks and tomorrow's gonna suck, or if you're the kind of person who says yesterday's a great day, today's a great day, tomorrow's every day above ground is a great day, both of those people are annoying. Because if you don't ever change your emotional response to the world around you, that is not healthy. That is the definition of pathology. If every day is terrible or if every day is wonderful, you're not calibrating your current mood to the current situation accurately. In fact, true well-being is the ability to say yesterday was awful, but today is better, where you're calibrating your current mood to the current situation. That's well-being. Now, with that in mind, we now know a lot more about how to go about understanding and measuring burnout. This is a conversation I had with my youngest child. This is Tatum. This is from about 8 years ago. She's 15 now. Tatum was picking her up from a soccer practice and strapping her into her car seat, and she looks up at me with these big, beautiful brown eyes, and she says, "Daddy, you are always talking about burnout, 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 burnout. What is burnout, Dad?" And so I said, "Well, honey, burnout's comprised of 3 pillars. There's emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. You're not following what Daddy's saying, are you?" She says, "I don't know what any of that means, Daddy. What is burnout?" So I'm like, well, you have to take a deep breath and kind of think about it for a second, because if I've been studying this for 25 years at that point, do I really understand what I'm talking about if I can't explain it to my daughter? I'll tell you what burnout is, honey. Burnout's what happens when it gets really hard to notice that something is funny or interesting or amazing. Burnout's what happens when you can't feel hope or gratitude or interest in what's happening in front of you. Burnout's what happens when you can't feel any positive emotion anymore. That's what burnout is. And she says to me, "Oh my gosh, Daddy, that is so boring." I used to tell all my friends you worked at Duke, and I'm not telling any of my friends that anymore. That is literally how that conversation went. But undaunted, we took what we call the Tatum definition of burnout back to the lab. We've published this multiple times. We've run randomized controlled trials. We've operationalized the definition of burnout this way. Burnout is when it's hard to experience positive emotions. This one tweak, we call this the Tatum definition of burnout, has taught us so much about our interventions, about the efficacy of our interventions, about our methodology. This has been really a breakthrough for us. Now, when it comes to burnout, we know that it's been rough for folks. It's not a good idea to say, "Hey, diet, and exercise, meditation, and yoga, like you want to get something heavy thrown at your head, go talk about those things in a work setting near you." Instead, we packaged, starting in 2014, we packaged the best available well-being strategies that were bite-sized, that were simple strategies. We packaged them together for busy, tired, cranky healthcare workers, and we put it through the ringer. This was the rubric that we used. We looked at over 200 different interventions, and we said, is it simple? Is it easy to do? Does it not take very long? Do I feel better right away? And do I feel better for a long time? And if the answer was yes, if I met yes to all 4 of those things, simple, brief, feel better right away, and feel better with an enduring effect, then we would put it in the category of, yes, let's test this in some randomized controlled trials, which is what we did. We're using a big NIH grant. What we found was that out of 200 plus interventions, I think there's like 212, we found 5, maybe 6 if you're generous, but 5 that met these criteria. It's hard to find interventions that are like this, but the ones that we found all had some interesting things in common. And the things that they had in common taught us a lot about well-being. They all had to do with kind of providing opportunities to cultivate little moments of positive emotion. The first one that we did in the neonatal ICU. This is a national sample of neonatal ICUs across the country. We did this with NICU nurses and neonatologists. And what the neonatal nurses said to us back then was, we'd go and ask them, we'd try to recruit for the study. They'd say, I'll consider your little well-being intervention. Like, remember, this is 2014. I'll consider your little well-being intervention, but I'm not going to put the baby down, and I better be able to do it with one hand. If I can do it with one hand, on my phone, and I don't have to put the baby down, I'll give you like a 1 minute, maybe 2 minutes tops, but that's all I'm going to give you. And so we're like, okay, challenge accepted. And we designed bite-sized interventions that took 1 to 2 minutes you could do on your phone with one hand while you're holding a baby. Thus, bite-sized interventions were born. The very first time we did this in the neonatal ICU, we showed that we can cause emotional exhaustion to go down and stay down for 6 months. We can cause problems with work-life integration to go down and stay down for 6 months. This was very exciting. We also did a follow-up at the 1-year point and showed that between the 6-month post and the 1-year post, emotional exhaustion continued to decline. Let me just kind of put that into perspective. That's as if you were taking antidepressants for, the entirety of that 6 months period. And then at 6 months, you're taking a stronger dose of antidepressants, and suddenly you're seeing an increase in the efficacy of the medication. But this intervention was done in 28 days. It was 1 to 2 minutes a day for 4 weeks, 28 days. That was it. And then you never did it again. Isn't it interesting that between the 6-month post and the 1-year post, they continue to get better? That we call this skills, not pills, because we're changing the way you interact with your environment, which helps you to bounce back after emotional upheavals, and it helps you to kind of build your well-being. We did the same thing. Next week, we exited the neonatal ICU. We went into healthcare work settings where we had healthcare workers that were clinical and non-clinical, and we saw that whether you're a surgeon or a hospital executive, or you work in IT or in marketing or in finance, it didn't really matter. We actually showed that we can cause emotional exhaustion to go down, stay down for a year. We can cause depression to go down, stay down for a year. Work-life integration problems, we can cause them to go down, stay down for a year. This was very exciting to us. But if you're paying attention, you might have heard me say it took 28 days to do the intervention the first time. So the first intervention was a 28-day long intervention. The biggest bit of feedback that these very smart, very vocal neonatal nurses told us was, hey, listen, 28 texts, to receive 28 texts from you to do this thing on my phone, that's way too many texts. So we're like, okay, one of the big things that we did from randomized control trial number 1 to randomized control trial number 2, which you're looking at now, is we shortened the duration down to 10 texts. So now it's 1 to 2 minutes a day for 10 days. We call this Wiser in 10 texts. Then the pandemic happened. And we were asked to take everything and put it into Zoom. I want you to just put everything into Zoom. So in a podcast with a JAMA editor, they basically threw down the gauntlet and said, hey, you know what you should do is you should put this into CMEs. You should put this into CMEs. And so we did. We actually put the entire bite-sized concept. If you're just doing it for 1 or 2 minutes a day for 10 days, can't we just take 10 minutes of 55-minute CME or CEU credit and have you do the bite-sized intervention as part of your continuing education? And it turns out you can. So we published this last year in JAMA Network Open, Wellbeing Outcomes of Healthcare Workers After a 5-Hour Continuing Education Intervention. If you finished, we found efficacy after 2 hours. When you went to hour 3, hour 4, and hour 5, we saw an increasing improvement in your well-being. What I thought was really interesting about this is that you can embed these bite-sized interventions into healthcare worker continuing education credits, and they like it. The QR code is right there. This has been evergreen. It's free. It was a randomized controlled trial. Now it's just free. You don't have to participate in research. The entire intervention, exactly the way it was for the RCT, is available for free for anyone clinical or non-clinical who wants to use it. That's the QR code right there if you're interested. These are the results. Every one of our 4 dimensions of well-being improved. Emotional exhaustion went down. Emotional thriving, kind of professional fulfillment, went up. Emotional recovery, bouncing back after upheavals, that went up. And work-life integration, actually problematic work-life integration was reduced. Then we gave the waitlist control the opportunity to do the intervention, and they replicated in every single dimension. They replicated the treatment group findings. It was a very clean outcome. It was a pretty significant improvement too. So that we delivered these 5 hours of continuing education credit over an 8-day period. So just to say, the emotional exhaustion for the healthcare workforce spiked 9 points in 3 years. I showed you that data at the beginning. We showed that in 8 days, we can cause it to go down 9 points. We can cause it to go down. That's not up to 9 points. That's the average was 9 points. So it took the pandemic 3 years to do. We can now undo in 8 days. Like, that was really encouraging to us. And we have continued to build onto that. And if this is interesting to you, I want to offer you kind of some more kind of insights into kind of what we're learning and where we're going with this. If you want to see how we did this, how did we keep people engaged? Because we had a remarkably high level of retention, which was amazing because we did a lot of our recruitment for this study during the Omicron phase wave of the pandemic, which was, you can imagine, it was really hard to get people to do anything that wasn't mission critical at the time. And what we asked people was, we said, listen, if you want to participate in well-being, but you don't have the time, you have to know this. We are going to give you an assessment. We're going to give you feedback about your assessment. And you're going to get these personal feedback with strategies to work on your well-being that are personalized to where you are right now. And I'd love to show you right now how we did that. So if you have a mobile phone, does anybody have a mobile phone? If you have a mobile phone, take it out, put it into your camera mode, and here's the QR code for this. I'm going to leave a 2-minute timer up there. If you go to the QR code, or you can enter the bit.ly link in there, you should see this pop up on your screen. I'm going to go ahead and put it in the chat as well, so that same little link there is in the chat. You can grab it from the chat. You can grab it from the screen right now. It will not take you 2 minutes to answer these questions, but it'll give you a chance to answer 5 quick questions, and then get personalized feedback about your responses. So I'll be quiet, give you a chance to look at your personalized feedback, and we'll pick it up from there. This just as a reminder, this is how we did it in the randomized control trials.
Hi, Bryan. I'm Leslie Hammer here, one of the faculty members. So while folks are finishing up, or maybe you'll get to this, but you started by talking about culture and talking about organizational level interventions, and this is really an individual level intervention. So how are you going to reconcile that? Are you moving to that point?
You are presaging the next 10 slides. Thank you so much.
Okay, fantastic.
Yeah.
Great.
Actually, it's about 9 slides from now. Yep.
Okay. I will hold tight then. Yes.
Yeah,
Thank you. Yeah, I appreciate you being here with us. Thank you.
Thank you for your comment. I hope to weave that in nicely. So you can see it didn't take me 2 full minutes to kind of answer those questions. You got some personalized feedback. It should have looked something like this, where it shows you your score, which profile 1, 2, or 3 that you had. If you are a 1 or a 2, or if you're a 1, that's kind of the most concerning score for emotional exhaustion. Guess what? 55% of healthcare workers meet the criteria for 1. I'm a 1 personally. So I use these interventions myself. If you're a 1, whatever you do better require minimal effort, because we just don't have the gas in the tank to do extra things. We have the very specific interventions dedicated, like a gratitude intervention, 3 good things, the well-being intervention, a sleep intervention, all for people who have an emotional exhaustion profile of 1. If you're a 3, you can do harder things. If you're a 2, you're kind of in the middle. What I think is interesting about all of this is that every one of these interventions that we have talked about have to do with positive emotion. They all help us to cultivate and curate our access to positive emotions. Now, this work is not my work. This comes from Barbara Fredrickson at UNC Chapel Hill. It must be amazing work, because you don't hear usually people from Duke saying nice things about people at UNC, but she is brilliant. She is amazing. She's been doing this work for 40 years. And she said, if I can channel Barb for a second, she'd say there's 10 of these positive emotions. They all are important for your well-being in different ways. There's joy, gratitude, serenity, interest, hope, pride, amusement, inspiration, awe, and love. They all help your well-being in different ways. Some of them are easier to access than others. Let me give you an example. It's easier to turn on the positive emotion of gratitude than it is to turn on the positive emotion of hope. It's easier to feel grateful for someone in the moment than it is to feel like tomorrow's going to be a great day. They're just different. Now, if you use gratitude first, it's easier to subsequently experience hope. So some of these positive emotions, if you sequence them very deliberately, they grease the skids to make other positive emotions, even more potent positive emotions, more likely and more beneficial. So we've learned a lot about, when you're doing interventions, how to sequence the positive emotions. What's the dose? What's the duration? What is the frequency of these positive emotions that make a big difference for your ability to kind of bounce back after upheavals? 2 things about positive emotions. One, it's how you get to feel like you're making a meaningful difference at work. I double dog dare you to feel like you're making a difference without experiencing one or more of these positive emotions, you just can't do it. Also, it's through positive emotions that we recharge our batteries when they get low. And here's a critical factor from Barb Fredrickson at UNC Chapel Hill. She says it's not the magnitude, it's not how hopeful you are or how grateful you are or how inspired you are. It's the frequency with which you experience a little bit of gratitude or a little bit of hope. It's the microdosing of the positive emotions that makes all the difference in the world. I think that's really helpful, because to go back to the question that we just heard a minute ago is, what do we do for groups? Because so far we've just talked about how to help individuals. And I want to share with you how we've converted these concepts into group level interventions. And then we'll go into some Q&A. So get your questions ready. We'll go into some Q&A here in about 15 minutes. So what I wanted to share with you is this. If you're familiar with the concept of leader rounding or leader walk rounds or safety rounding, the original concept is you have a senior leader who comes into your work setting and says, hey, how are we going to harm the next patient around here? And what can we do to prevent that? And in 1999, that was a fabulous way to kind of surface patient safety and risk-related issues. In 2026, asking this question is a great way to get something heavy thrown at your head. Instead, we encourage you to take what we've learned about positive emotions, the role of positive emotions in our well-being, and integrate that into your well-being leadership strategies. So instead of saying, how are we going to harm the next patient, you could say, what are 3 things that are going well around here and 1 thing that could be better? Now, by doing this, I'm asking people to tell me, what are they looking forward to? Who do they want to give a shout out to? What are they grateful for? Please tell me what gives you meaning at work. And by doing that, we're actually triggering, even if it's a small dose, we're triggering positive emotions. Positive emotions, we call this positive rounding for that reason. Positive emotions are the key to helping with the well-being of individuals and with groups. We published this, the Joint Commission actually did a press release about it, saying there's a new way of doing rounding in town. Here we're looking at rounding across, this is 400 different work settings here. Do senior leaders ask about what's going well? You can see in the bottom quartile here, this is the percent of people saying, yes, senior leaders ask about what's going well. This is just percent yes. So you can see in the 4th quartile, they're not doing very much asking. In the 1st quartile, they're doing a lot of asking, and it's linear. In fact, every dimension of well-being, of engagement, of culture, every dimension is directly related to how frequently we're being asked by our leaders what's going well. For these domains that we talked about at the beginning, quality improvement readiness. If you're asking me about what's going well, that's the green quartile here. That dimension of culture is better. What do I think about my leader? I think more positive of my leader if I'm being asked about what's going well. What's my teamwork like? Can I ask questions, clarify ambiguities, and resolve conflicts? Yes, I can do a better job of that when I'm working in a work setting where you ask me about what's going well. Patient safety climate. Would I feel safe being treated here as a patient? Well, more safe when you ask me about what's going well. Look at the reverse pattern here for emotional exhaustion. My emotional exhaustion is lower, significantly lower when you ask me about what's going well. What about burnout climate? How crispy are my colleagues? Remember the social contagion? Yes, they are less crispy if you're asking me about what's going well. Even my work-life balance is better if I'm in a work setting where I'm being asked about what's going well. But wait, there's more. We actually put into a horse race traditional patient safety rounding and positive rounding. And we were doing this when we were trying to look at the validity of a new scale called the psychological safety scale. And what we found was pretty interesting. The left-hand panel here, panel A, is safety rounding. Panel B is positive rounding. Now, I want to leave you with a really important message here. Number 1, safety rounding works. Number 2, positive rounding works better. It just does. It doesn't take longer. It just works better. So if instead of asking about what's broken, instead you ask about what's going well, you're actually creating psychological safety. Even safety climate, which we thought would be better in the patient safety rounding condition, that is half the effect size as what we see in the positive rounding. So you create a lot of psychological safety when you're talking about what's going well. Not only that, psychological safety is significantly more effective in the positive rounding dimension and condition, and emotional exhaustion is significantly lower in the positive rounding condition. Both work. Safety rounding works. Positive rounding just works better. And now you can see the thread start to connect to the work of David Hurtado and Abigail Lenhart in your department. I'm really excited to kind of start to pull this through, because what we've learned, and I can go back to the data that this is from the Michigan Hospital Association, where we looked across 31 hospitals, and we actually found something really interesting. One of the items that we use to measure leadership is in my work setting, in my clinic, in my work setting. My nurse manager, my medical director, my local leader regularly makes time to provide positive feedback to me about how I'm doing. So that is positive emotion being elicited by my leader. For every 10-point increase in leadership, we saw an almost 3-fold reduction in the odds of burnout for that respondent. That is a very tight coupling of the way I view my well-being and the way I view my leader. And it depends on what that leader is doing. Don't take my word for it. Separate data from Lottie Derby and Colin West at University of Colorado and at Mayo Clinic. They also, with a separate data set, separate question, separate people, healthcare workers. My immediate supervisor encourages me to develop my talents and skills. That was their number one predictor of burnout in their sample. I think what's interesting here is that it's not about leaders being in charge of people. It's about taking care of the people in your charge. That is about well-being informed leadership. That is about taking the time to make sure we are helping people to feel seen and heard. I'll give you another example. So we just talked about positive rounding. Let me give you another example. In 2017, we were approached by our risk managers at Duke, and they were saying, you keep asking, Bryan, you keep asking about a peer support program, but I want to see some actual numbers. I don't have any idea how often people even need peer support here at Duke. And so we said, okay, well, let's measure it. So we did a safety culture survey. We tagged on a question on that survey. It was an 80% response rate, 400 work settings, 10,000 respondents, and we published the results here. The question was this: individuals emotionally traumatized by an unanticipated clinical event within my work setting receive appropriate support from this health system. That's it. And you're looking at the percent of people who agree. And so you can see this quite a distribution here. If you look across 400 work settings, quite a distribution of people saying, yes, people who second victims of harm in healthcare receive the support that they need. If you take these quartiles, the fourth quartile, compared to the first, you'll see something really interesting, kind of like what you saw with the positive rounding. You'll see that at the work setting level, there are significant differences in all these culture and well-being and engagement domains. Quality improvement readiness, local leadership, teamwork, patient safety, emotional exhaustion, burnout climate. That's really important, because this is if you look at it by quartiles. That's at the work setting level. If you just look at the Duke Health level, what is the percent of people in the green who said, yes, they're supported? That was about 2,341 respondents. And you compare them to the people in the red, they said they did not feel supported. That was the 1,673 respondents. The way I view improvement readiness, local leadership, teamwork, safety, emotional exhaustion, the exhaustion of my colleagues, and my work-life balance, those are all whopping differences. Let me just pause here on this slide, because we're almost done. I hope you got your questions ready, because we're about to go to Q&A. Let me pause here on this slide, and I want to say, I have been doing this work for over 3 decades. I've never seen a single variable differentiate being in a positive work environment from being in a negative work environment so clearly as whether or not you feel like your mothership has your back on your worst day at work ever. If my mothership has my back, I'm all in. I'm showing up. I'm going to bring my A game. If I don't feel like my mothership has my back, I am tentative at best when it comes to kind of putting in the effort that my patients really deserve. All of this is to say, whether we're talking about peer support or positive rounding or these well-being individual level RCTs, I want you to know the following. Number one, healthcare worker well-being is a social contagion. We need to measure it as such, treat it as such, both in our assessments and in our interventions. Number two, these randomized controlled trials show the efficacy of these bite-sized interventions. Simple things, 1 or 2 minutes a day for 10 days, that's amazing. And well-being is a science. There's so much work left to be done in this space, where I'm really excited to work with folks like your faculty to learn from you and to share with you, because this is such a critical time for the field. If you're interested in more, you can check out our website, cause.dukehealth.org. We have institutional resources here on the left-hand side. We have a bunch of individual resources as well. They're both important. We need both in order to kind of recover from this mess that we're in terms of emotional exhaustion at the kind of healthcare system level. Every month at Duke, we have a different well-being seminar, about a different topic. They range in things from like the neuroscience of hope to dealing with difficult colleagues. That's affectionately named How Do You Work with the Jerk? We have one on grief, we have one on humor, we have one on sleep, lots of different topics. Every month it's a different topic, every month it's a different tool. The idea is that at the end of the year, you have 12 tools and 12 topics and 12 hours of continuing education credit, but you have a quiver with 12 arrows in it at least to work on your well-being. If you take the 5 hours that we published in Jumma Network Open, that's the Wellbe Duke, I gave you this QR code already, and the 12 hours of our monthly series, you put them together, that's how we train well-being ambassadors so that we can now build capacity to assess and manage well-being at the clinic level, at the work setting level. What the cath lab needs is so different from what they need in peds, which is different from what they need in our outpatient clinics, which is different from what they need in the cafeteria, which is different from what they need in marketing. We have to be able to tailor our current interventions to the needs of a specific work setting. And the best people to do that are folks who understand the science, they understand the methods behind it. We also publish our stuff on LinkedIn. If you're interested, you can follow us on LinkedIn. We put, anytime there's a new video or article or tool or resource, we put it out there on LinkedIn. I do not believe that social media is good for you. I just want to put that out there. I think that social media is bad for you, but there are fewer people death scrolling on LinkedIn than there are on the other platforms, and it's a great place to kind of share content with folks. So if you are on LinkedIn, you can get stuff from us that way. And with that, I've now talked about a lot. What I'd love to do now is give you an opportunity to ask some questions. And if you care or are interested, I can even provide an hour of continuing education credit for what you've witnessed so far. I have to wait I have to have spoken for 40 minutes before I can show this QR code, and we've spoken for 40 minutes already. So with that in mind, I'll kind of pause here, and we can go to the chat, or I think that David had said earlier that some people they can unmute themselves and ask questions. But I encourage you to ask questions, ask me to clarify anything that's unclear, and feel free to push back on anything that you've heard. I'm looking forward to the conversation.
Thank you, Bryan. That was a dynamo of a presentation, lots of energy and ideas. I see, let's see, so I interpret that as you have a question, so go ahead.
Yeah. So thanks again, Bryan. And yeah, I had been hearing about your work through David and Abby for a while, and I'm an industrial organizational psychologist and an occupational health psychologist, and I've been studying supervisor support strategies for the past 25, 30 years, and evaluating the effectiveness of training leaders and supervisors on how to increase their supportive behaviors, and showing those effects on many of the outcomes that you've been talking about. And I too have been really shocked. My team has been absolutely shocked by the continued demonstration of effectiveness of this, what I call a very basic intervention. I don't know if it's as basic as yours, but it's pretty. It's been pretty much. I mean, I wouldn't call it a wise intervention, but it's basically it's a training that takes about an hour, and it's computer based or in person, and it's on simple strategies of interaction and teaching leaders how to basically following some supportive strategies, but I always say it's not rocket science. And so I was wondering, can you just talk a little bit more about now what, you talked about the 1-minute strategies at the individual level. So what the supervisor strategy or the leadership strategies are, can you just give a little bit more context to those? Is it really what you were saying is kind of having these, having the roundings, the positive roundings, and, going in with a positive attitude, checking in and just bringing forward the positive attitude. Are there any other kind of components there?
Yeah, so that's how I came to meet David. I was a reviewer on one of his papers, and I was like, "This sounds so similar to what we're doing." And I was like, and ever since I've been promoting their stuff whenever I'm speaking. And here's why: when you do positive rounding, it's not the first time you go in. It's usually the third or fourth time that you've come back and you've asked these questions and you've shown curiosity and you've engaged with people. That they're like, "Oh, this isn't a trick. They're actually curious about how I'm doing. They want to hear about how I'm doing, and they're back again. It wasn't just a one and done thing. So there's something about the recurring nature, and we've looked at the again. There's this dose and duration and everything else.
Right.
They typically are a monthly format. They typically are about 30 to 40 minutes with people coming and going while there's talking. Sometimes they're much shorter. Sometimes they're much longer. Sometimes they happen in an empty pod. Sometimes they happen in a hallway. Sometimes we've had British executives have a formal tea time where we talk about safety and well-being. There's all kinds of very like make it your own. But the idea is to make it predictable and create these opportunities for connection and to help people feel like the stuff that you're doing is hard. I can't take away all your stress, but I can recognize that you're doing amazing things. That sounds an awful
Yep.
lot to me like the work-life check-ins
Mhm.
that's happening out in Oregon, which is amazing. So that's when science is at its best. Because I didn't grow up with David. We met each other because we were doing similar things, and we kind of ran into the same finding, which is that if you give people these simple strategies to do what seems too good to be true, guess what? Well-being improves. Like that's pretty cool.
Yeah, and part of so I'm on part of David's project, and so he has incorporated some of the trainings that my team has developed, and some of the kind of conceptual aspects of the trainings, and again, it's like this. I agree. I mean, like I said, I always say it's not rocket science. It's just basically teaching people some very easy people relational strategies, and if they get it, and they get it, and it's leaders, and you see these amazing outcomes. So I look forward to looking more into the strategies that you have that you have studied, and happy to share some of what
I was
my
just going
team,
to say,
and
I was
yes,
just going to say,
yes,
I'd love to see it.
yeah,
Love to see
I'll follow up with an email.
it.
Great, thank you so much for presenting here with us.
Absolutely. It's my pleasure.
Abby, hi.
Hi, Brian. Thank you. Sorry you guys heard me. I'm moving offices today, so I'm back in an old office. Um, I love seeing your presentations again, and just so inspired by the work. I wonder a little bit about how you coach the cynical leader.
Mm.
I have a lot of leaders that I work with who um, the positive psychology piece feels too woo woo to them. And I was wondering if you had any experience or recommendations for sort of trying to implement more of the positive psychology with some of the leaders who are resistant.
Abby, I love that question, and boy, I think we might be talking about the same kinds of people that we interact with on a regular basis. I think I would say a couple things. Number one, my mentor pounded it into my skull during my training. Like, if you're going to ask people to do things that seem extraordinary, you better have extraordinary evidence. You better have big data sets. You better have randomized controlled trials. You better have tight methods. Like, bring receipts. If you're going to ask them to do stuff that sounds too good to be true, bring receipts. So number one, having the evidence behind it is really, really important. Number two, there's going to be about 20% of your executives who aren't cut out to do this anyway. They like to send them out and do it would be to remove some of the progress that might be happening organically anyway. In an ideal world, I mean, I think that uh, there's probably some individual difference variables. Like I don't know if you're familiar with the concept of tolerance for ambiguity. Leaders that have a low tolerance for ambiguity are terrible at this stuff. But leaders that have a high tolerance for ambiguity do well. And so one question that we've kind of experimented with is, should we be putting some kind of selection criteria? Should we be doing some profile work where we're selecting executives that fit this? That's really hard to do in a health system. And what we've actually found is oftentimes you're better off talking to your patient safety officer and say, like, this is what we're looking for in an executive. Who do you think is going to really do this well? Like, oh, definitely not these 3 people. These other eight people, for sure. And so that can be easier than to have someone nominated. Can be easier than politically having them fill out a questionnaire and saying you failed because you don't meet the psychometric profile for someone who should be good at this. So that's been tricky. We've been talking about that for a long time. Interestingly, the same types of people who do really well at safety rounding tend to do really well at positive rounding. So it's not the format, it's the comfort level that they have with engaging with people at the front lines. So that seems to be the, are you going to go back to that work setting and talk to the same 2 nurses every month? Or are you going to make a deliberate effort to talk to different people each time you go back? So those kinds of things make a real difference in the efficacy. This is about dose and duration and frequency, right? To get it just right. But those are some. It's a great question, and I would say one more thing, which I wish somebody had told me this earlier in my training, which is you're not going to make everyone happy all the time. It's okay. It's all right. That's just not your job to fix everybody. That's not your job. I wish somebody had told me that 30 years ago. That would have been great.
Susan, go ahead, please.
Great, thank you. That was just a fabulous talk. I cannot tell you how much emotional excitement that created for me. So I have an affiliation in psychiatry. We're really interested in willingness to engage in effortful responding, be that physical or be that cognitive mental effort. And people will often blame anhedonia and apathy for failures to engage in cognitive effort, and it seemed like a lot of the constructs you were talking about had something in common there. So in my 2-part question, I'd be very interested to know, to what degree do you think emotional exhaustion overlaps with apathy, anhedonia, or even anergia and fatigue? And in my second part, I wondered whether you had tried any of these activities as interventions in clinical populations or caregivers.
Well, those are great questions. So the second one is yes. I have a number of colleagues in that specialize in cardiovascular disease and in oncology that are trying these out with their patients now. We have historically made it available to anyone 18 or, well, it started off being healthcare workers 18 and older, and then to avoid some of the pediatric kind of barriers with IRBs, we made it available to patients and family members 18 and older. The interventions work, as far as we know, down to 9-year-olds without any significant modification of instructions. So there's nothing kind of limiting that. But we're not trying to do this for the world yet. We're trying to kind of get this right for healthcare workers first. So I mean, the answer to the second question is basically, watch this space. We're working on that now. Now, a lot of these tools outside of our lab, like the 3 good things intervention, where every day for 7 days, you write down 3 things that went well that day. And that helps to upregulate the amygdala. That helps with your ability to do autobiographical, positive emotional kind of reconciliation at the end of the day, which is really interesting stuff. I'm fascinated by that work. Kimberly Young's done that work at the University of Oklahoma. They've actually done those types of interventions, like gratitude interventions and other positive psychology interventions, have been used on clinical populations. They've been used in men who have sex with men. They've been used with oncology patients. They've been used with people that have sleep disorders. That's not my area of expertise, but I'm familiar with the work when I'm writing up my stuff, and I have to cite how it's been used in other populations. I'm at least aware that it's being done like that. But your other question was very specific. And it is like, how does emotional exhaustion overlap with some of these other concepts like anhedonia? So let me just say, we get this question a lot. Is emotional exhaustion really that different from depression? And if you ask Renzo Bianchi, and I can tell you, I'm plugged in now, because since I became a chief wellness officer, I'm plugged in with the chief wellness officer network. And I can tell you, I was not aware that they shared my same frustration with a particular researcher in Europe, Renzo Bianchi, who keeps saying there's no difference between depression and emotional exhaustion. The presentation of symptoms is the same. The treatment's the same. We should stop calling it burnout. Stop calling it burnout. And here's what I'm noticing. I think that's wrong, because right now, you and I are comfortable calling this stuff burnout. And I'm more willing to work on burnout than I am to work on depression. So I think that the nomenclature isn't really a barrier in that way. Is it true that treatments for depression often work on emotional exhaustion? Yes, that's true. Depression, though, is considered a global pathology, where it affects like your personal life, your private life. It affects like your immune system function, everything else. And the World Health Organization has defined emotional exhaustion or burnout as a work-related, a vocational specific syndrome. I think the World Health Organization was trying to do the right thing, but the truth is emotional exhaustion predicts immune system function. It predicts marital satisfaction with your parenting. It predicts all kinds of things outside of your work. So I think that the World Health Organization kind of did a disservice by creating an artificial barrier. Now, is emotional exhaustion the same thing as depression? No, I measure both all the time, and they're typically related at about 0.7, 0.72. Very consistently about 0.7. That's like height and weight. Height and weight are not the same thing, right? They're highly related, but they're not the same thing. So I think that the truth is we have to be careful about calling it a vocationally specific syndrome, but it does have very similar attributes to a lot of other pathologies that we have to deal with in patient populations.
Great, thank you so much.
Absolutely. I hope you didn't mind. Hope you didn't mind my British tea impersonation.
Yeah, we got a few British members in the institute, so but they're known for the good humor, right? So it's all good. Thank you so much, Bryan. This was wonderful, and appreciate. We have a copy of your slides, so if anyone would like it, I'm happy to forward them. Thank you again, and yeah, see you next time, man. Excellent pronunciation of my last name, by the way.
Thank you, my friend, and thank you all for your questions, and good luck, and please feel free to reach out to me for any reason.
Thank you very much. Have a good one, everyone.